The following podcast is part of a certified educational activity titled Scoring Comprehensive Type 2 Diabetes Mellitus Management Goals, examining the multifaceted effects of GLP-1 receptor agonists. Access the entire activity and complete the post-test at peerview.com/ZKJ860. Downloadable slides and practice aids are also available.
Hello, this is Dr. John Buse from the University of North Carolina School of Medicine in Chapel Hill. In today's presentation, I'll discuss why GLP-1 receptor agonists have risen to the top of the treatment hierarchy for type 2 diabetes, how the agents within the class differ from one another, how to identify the patients who will benefit the most from these multifaceted agents, and what you need to tell patients to ensure they'll succeed with them. You'll then have the opportunity to apply the latest evidence to some patient cases through a series of challenge questions. So let's get into the meat of the matter. As you know, diabetes is very common. In 2022, 37.3 million people had diabetes. That was 11.3% of the population. The majority are diagnosed, but still 23% of those living with diabetes are undiagnosed. Prediabetes is a bigger problem. 96 million people 18 and older have prediabetes, which is 38% of the adult U.S. population. And over the age of 65, it's nearly 50% of the population has prediabetes. But how do we screen for diabetes in people at risk? So the new recommendations is to screen everyone over the age of 35 who has overweight or obesity, and screen at younger ages in populations at high risk, like people with a family history of diabetes and virtually all ethnic and racial minority groups. The recommendation is to repeat the testing at least every 3 years if the results are normal. If someone falls in the prediabetes range, the recommendations are to screen at least every year. But in the process, we will detect people with unrecognized diabetes. There are 3 approved screening tests. The fasting glucose test, which requires at least 8 hours of fasting, preferably in the morning. The 2-hour glucose tolerance test, that requires at least 3 days of a high carbohydrate diet, at least 200 grams per day of carbohydrates as preparation for the test, and then an overnight fast, and then consuming 75 grams of oral glucose and measuring a glucose level 2 hours later. So much more cumbersome. And then the A1C test, which is the easiest test by far, the preferable test in many settings, mostly because, particularly in these younger patients with regards to screening for diabetes, they're often coming to medical attention because of some intercurrent event. They twisted their ankle playing softball, and they're being seen in an urgent care facility. That's a great time to screen. I don't know when a young patient who might be at high risk might show up again in a doctor's office. And the A1C test allows you to screen people independent of their fasting status and also independent of any acute or intercurrent illnesses. Now, diabetes is associated with 2 different kinds of complications. We have macrovascular complications and then microvascular complications. On the left are the macrovascular complications: coronary heart disease, heart failure, peripheral arterial disease, and stroke. And each of these occur in on the order of 10 to 20% of people with diabetes. There are many more details that are available on this beautiful slide, which you can peruse at your leisure. On the right is the microvascular complications, and that's historically thought of as retinopathy, neuropathy, and nephropathy. And as you can see, each of these is present in closer to 30 to 60 to 70% of the population with diabetes. That's a bit dependent on how long the population has had diabetes and what their level of glycemic control is. So both with regards to the macrovascular complications and the microvascular complications, there are multiple opportunities to screen for early manifestations, intervene specifically to reduce the risk of progression. And certainly, most people with diabetes with good access to care should not experience disabling complications from diabetes. Why am I so enthusiastic about detecting diabetes by screening? I think it's really this kind of data. There is randomized controlled data that suggests that this observational data is true, but I'll run you through this relatively complicated slide. On the left are the microvascular complications, in the middle, macrovascular complications, and to the right, mortality. And what we see as we go from the bottom of the slide to the top of the slide is differences in what they call the early exposure period. So from 0 to 1 year of exposure, all the way at the top of the slide to up to 7 years of exposure. And what you see with the different colored dots is different levels of hemoglobin A1C. Hemoglobin A1C of 6.5 to 7%, with the circles, hemoglobin A1C of 7 to 8%, with the squares, a hemoglobin A1C of 8 to 9%, with the triangles, and a hemoglobin A1C over 9% with the green diamonds. And so what you see as you go from the bottom of the slide to the top of the slide, that with higher levels of hemoglobin A1C, there's an increased hazard ratio for, in the left column, microvascular disease, in the middle, macrovascular disease, and to the right, mortality. So the conclusion from the authors of this paper was, among patients with newly diagnosed diabetes and 10 years of survival, hemoglobin A1C levels greater than 6.5% for the first year after diagnosis were associated with worse outcomes. Therefore, immediate intensive treatment for newly diagnosed patients may be necessary to avoid irremediable long-term risk of diabetes complications and mortality. So early glycemic control matters, and detecting people by screening gives you the best opportunity to sort of nip the process of developing complications, to nip it in the bud. So now we turn to the most recent American Diabetes Association and European Association for the Study of Diabetes joint so-called statement regarding the management of hyperglycemia and type 2 diabetes. And the thing that's changed in this most recent guidance from these two diabetes organizations are, first of all, that we now recommend simultaneous and equal emphasis on addressing the 4 components of care, namely the medications for glycemic management, weight management, cardiovascular risk management, and in those at high risk or with prevalent cardiorenal disease, cardiorenal protection through the choice of glucose-lowering medications. So let's talk about medications for glycemic management. The top-line recommendation is to choose approaches that provide the efficacy to achieve goals. What do we mean by that? So if you have a patient with a hemoglobin A1C of 9%, that you believe should get to an A1C level of, let's say, less than 7% based on their age and other comorbidities, you're looking for an agent that's going to be able to lower the A1C from 9% to less than 7%, or you need something that's going to be able to lower A1C by at least 2%. And what could you use to pick an agent? Well, what we suggest is that it could be metformin, or one or more agents, including combination therapy, that provide adequate efficacy to achieve and maintain the treatment goals. So in the example that I gave you a moment ago, you wouldn't want to pick a single agent to get a greater than 2% lowering of A1C as a sort of expectation. Certainly, not a DPP-4 inhibitor or metformin monotherapy. That's very unlikely to occur. You might pick a combination, or you might pick one of the very high efficacy glycemic strategies that we'll talk about in a moment. And the third point from this slide is to consider the avoidance of hypoglycemia as a priority in high-risk individuals. And those high-risk individuals would be people who are at high risk for developing hypoglycemia, people who are very physically active or have erratic schedules, but also people who might have high risk as a result of hypoglycemia, like the frail elderly or people that do construction work or law enforcement work. And for some patients, these high-efficacy approaches may include the GLP-1 receptor agonists, as we'll talk about in a moment. The second component of care is achieving and maintaining weight management goals. The critical aspect of this is to set the individualized weight management goal and to pursue them with the kind of vigor that you might pursue in managing the glycemia in the setting of type 2 diabetes. And specifically, when choosing glucose-lowering therapies, consider regimens with high to very high dual glucose and weight efficacy. And with regards to these medications for weight loss, and particularly those with dual glucose and weight efficacy, that might include the GLP-1 receptor agonists as well. Third, let's consider the cardiorenal protection based on the choice of glucose-lowering medications in people at high risk for cardiorenal disease. The recommendation is for patients with chronic kidney disease, defined as an estimated GFR of less than 60 or a urine albumin to creatinine ratio of greater than 30. In those patients, it's recommended that they be on a maximally tolerated dose of an ACE inhibitor or ARB, and preferably use an SGLT2 inhibitor with primary evidence for reducing chronic kidney disease progression. If that is not tolerated or contraindicated, the recommendation is to use a GLP-1 receptor agonist with proven cardiovascular benefit. And if additional cardiorenal risk reduction or glycemic control is needed, to consider combinations of SGLT2 inhibitors and GLP-1 receptor agonists. In patients with atherosclerotic cardiovascular disease or at high risk, and high risk here is defined as people basically over the age of 55 with risk factors, or perhaps people a little bit younger with multiple risk factors, the recommendation is to use either a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit. And if additional cardiorenal risk reduction is required or additional glycemic control needed, consider a combination of SGLT2 inhibitors and GLP-1 receptor agonists. And the setting of heart failure, whether heart failure with preserved ejection fraction or a reduced ejection fraction, to use an SGLT2 inhibitor with proven heart failure benefit in this population. And then lastly, with regards to the positioning of GLP-1 receptor agonists here, the sweet spot is really the role of GLP-1 receptor agonists in preventing atherosclerotic cardiovascular disease and the mechanisms of which we'll talk about in a moment. When necessary in the setting of chronic kidney disease, or arguably in heart failure as well, if additional glucose lowering is needed, there is some suggested benefit of the GLP-1 receptor agonist in those settings as well. But what makes the management of diabetes challenging is that we have to do all of this at the same time. Pick glycemic lowering strategies with adequate efficacy, and considering using agents that provide for a meaningful reduction of both glucose and weight, and to establish weight management goals and pursue those targets with equal vigor to our pursuit of glycemic targets and cardiovascular risk factor management, And then finally, the use of these potentially life-saving therapies, GLP-1 receptor agonists and SGLT2 inhibitors, in patients with atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, or frankly, in people at high risk of those complications. So what's the benefit of the GLP-1 receptor agonists in type 2 diabetes? They have very high efficacy in head-to-head trials, even against multiple daily injections of insulin, basal bolus insulin therapy. The high efficacy GLP-1 receptor agonists, and we'll get to that in a moment, like tirzepatide and semaglutide, are equivalent or greater in efficacy than everything, including insulin. They are arguably the most effective weight loss drugs that are available currently, and we'll talk about that more in a second. They reduce systolic blood pressure in a meaningful way. They have very low intrinsic risk of hypoglycemia. They can amplify the hypoglycemic effects of sulfonylureas and insulin. So often as we're adding these GLP-1 receptor agonists, we're reducing or eliminating the use of those agents. Because they have low intrinsic risk of hypoglycemia, there's no need for routine blood glucose monitoring. And for most, when you take it, is unimportant. It's only that people develop strategies to take their medications on a regular basis. They have very broad activity. We've mentioned already the glycemic efficacy, but more exciting is the effects to protect the heart, protect the brain, and protect the kidney. And the mechanisms by which this is accomplished is uncertain, but there are many mechanistic pathways that are potentially contributing. I think the smart money or the most guesses are on anti-inflammatory pathways. Personally, I think there may be something more specific in the sort of vascular biology that is promoted by GLP-1 receptor agonists, including promoting plaque stability and endothelial function. But in any case, the GLP-1 molecule and these GLP-1 receptor agonists have very broad effects that seem to be beneficial in general. Now, there are 8 GLP-1 receptor agonists that are currently marketed in the United States. We have exenatide as a twice-a-day formulation, the original product that was released, I believe it was in 2005. We have daily products, including an oral version of semaglutide. We have daily injected products, liraglutide and lixisenatide. And then we have 3 weekly products, exenatide in the once-weekly formulation, dulaglutide, and semaglutide. And you can see the brand names there. We also have something that is technically a GLP-1 receptor agonist, but more specifically, it's a GIP and GLP-1 receptor agonist. It's a single molecule that has activity at both ends of the molecule, both on the GLP-1 receptor and the GIP receptor. So it's viewed as a separate class, but we are including discussion here because it does have GLP-1 receptor agonist activity, and that's the new kid on the block, tirzepatide. And then we do have fixed ratio combinations of insulin and GLP-1 receptor agonists in the form of insulin degludec when liraglutide is combined with insulin degludec, and when lixisenatide is combined with insulin glargine. Now, this is a visualization of the A1C reduction by the various GLP-1 receptor agonists, generally in the setting of being added to 1 or 2 oral agents. And you can see that the greatest efficacy to date has been demonstrated with this new agent, tirzepatide, the dual GIP and GLP-1 receptor agonist. Semaglutide is generally associated with similar A1C reduction. Liraglutide and dulaglutide just a bit lower. And then the other agents still providing for important hemoglobin A1C reductions as effective or more effective than virtually all the other anti-hyperglycemic agents. But the A1C reduction with high-dose tirzepatide is truly awe-inspiring, with A1C reductions on the order of 2 to 2.5%, and the majority of patients achieving hemoglobin A1Cs even less than 6%. This is a look at the mean weight loss after 24 to 68 weeks as expressed in kilograms. Again, similar kind of analysis in patients with type 2 diabetes on 1 or 2 oral agents. Again, tirzepatide in its highest dose associated with nearly 15% reduction in weight overall. Semaglutide providing for more like a 10% reduction in weight. And then the other agents falling slightly behind in that regard. But again, even the agents with the least efficacy in this space are generally agents associated with the most efficacy with regards to anti-hyperglycemic therapies for weight reduction. So all of the GLP-1 receptor agonists provide for meaningful weight reduction, tirzepatide and semaglutide being the most effective and associated with quite impressive weight reduction in the setting of diabetes management. To summarize, the GLP-1 receptor agonists are associated with excellent improvement in hemoglobin A1C, moderate weight loss up to 15% over 6 to 12 months. And when you look at the literature, you'll see some higher numbers. Remember, in general, when GLP-1 receptor agonists are used for managing obesity in the absence of diabetes, we tend to see higher numbers. The only agents that are approved today are semaglutide and liraglutide from this class for obesity management in the absence of diabetes. Tirzepatide will be submitted to the FDA for an obesity indication in the near future. They're also associated with modest improvements in blood pressure, no increased risk in hypoglycemia. The adverse events are largely gastrointestinal, and the safety considerations, or things that we should be discussing with patients, include the possibility of increased gallbladder events, the possibility of acute renal failure related to nausea, vomiting, diarrhea, dehydration, the possibility of pancreatitis, the possibility of medullary thyroid cancer, which is a warning within the package insert. So let's take a comparative look at the GLP-1 receptor agonists. Joshua, his BMI is over 32. He's 5'10" and weighs 235 pounds. His hemoglobin A1C is 7.3% and blood pressure 142 over 87. His lipid panel shows that his LDL is above target and his HDL is borderline. He has a past history of prediabetes, and clearly he's obese today, but was previously recognized as only being overweight. He's not on any medications. He works as an electrician, spends a lot of hours on the job. He's divorced, lives alone, and is generally eating at fast food restaurants between clients and on his way home. At the previous physical 14 months ago, his BMI was 29.5, so just at the borderline of obesity. His A1C was 6.3%. His blood pressure was 135 over 72, and his total cholesterol was 185. So he's had a sort of decline in his numbers with weight gain, and now a suggestion at least of frank diabetes with a hemoglobin A1C of 7.3% and hypertension and hypercholesterolemia. Let's talk more about the GLP-1 receptor agonists in detail because they're not all exactly alike. With regards to the pharmacokinetics. We have short-acting agents, exenatide and lixisenatide, half-lives on the order of 2 hours. And then long-acting agents, exenatide once weekly, liraglutide, semaglutide, dulaglutide, and tirzepatide. And these have half-lives adequate so that they cover 24 hours a day when administered as prescribed. So liraglutide is once a day. The other agents on the list are once a week. With regards to structure, we have exendin 4-based structures. These are the most, the highest affinity GLP-1 receptor agonists, so exenatide and lixisenatide. And then we have the GLP-1 based human structure for liraglutide, semaglutide, and dulaglutide. And then the GIP and GLP-1 human amino acid sequence based tirzepatide, the first dual GLP-1 receptor agonist. The issue with the exendin 4-based structures is because it is a xenopeptide, there is a higher risk of developing antibodies, and in pretty rare cases, 8% or so of patients, these antibodies can actually sort of block the activity of the drug. With regards to size, we have smaller agents and then we have bigger agents. The bigger agents are generally the result of what we call fusion peptides. So dulaglutide is a GLP-1 receptor analog that's been fused to an antibody structure, creating a large molecule. And this provides for advantages with regards to duration of action, but may explain why dulaglutide, though highly effective as a glucose-lowering agent, isn't quite as effective as one might expect with regards to weight loss. So we think the smaller agents are able to better get into the areas of the brain where they affect satiety and appetite, and therefore are able to promote weight loss. And then we have one agent that has been co-formulated with a carrier molecule, enabling us to provide semaglutide in this oral formulation as a once-a-day pill. Now, the big excitement around the GLP-1 receptor agonists in managing type 2 diabetes started with glycemic efficacy and weight loss, but really came to prominence with the publication of the LEADER trial, the first of the GLP-1 receptor agonist trials that demonstrated cardiovascular risk reduction with liraglutide. Now there are many such studies, which we'll go through in some detail, and even meta-analyses to show not only a reduction in the primary cardiovascular endpoint, heart attack, stroke, or cardiovascular death, but then in each of the components, cardiovascular death, fatal and non-fatal MI, fatal and non-fatal stroke, but also in all-cause mortality, in hospital admissions for heart failure, and even in the composite kidney outcomes that include macroalbuminuria. We've shown a very similar and meaningful, on the order of 10 to 20% reduction in those endpoints, with numbers needed to treat, for instance, for macroalbuminuria, as 47 cases treated for 3 years to prevent one event, 65 for the MACE-3 endpoint, and all of those being statistically significant. The worsening of kidney function, generally a doubling of the serum creatinine, a reduction in an estimated glomerular filtration rate of at least 40%, or kidney death, or the need for dialysis or transplantation, that didn't quite reach statistical significance, but certainly a suggestive trend in that regard. So these cardiovascular outcome trials in general have demonstrated very broad-based positive benefits beyond glucose and weight lowering. To take a deeper dive on the 3-point MACE endpoint, heart attack, stroke, and cardiovascular death, we see that virtually all the trials land to the left of the center line, indicating a trend for benefit. The only agents that had demonstrated benefit that was included in the package insert of the drug were liraglutide, semaglutide, and dulaglutide. Albiglutide and epaglenitide had very impressive results, but aren't currently marketed, and that's the reason why we haven't highlighted it here. But a consistent effect across trials, except for with lixisenatide for the 3-point MACE. Lixisenatide is administered once a day, but only has a half-life of about 2 to 3 hours, and probably just doesn't provide for the 24-hour-a-day, 7-day-a-week coverage that may be necessary for cardiovascular risk reduction. With regards to cardiovascular death, we see a similar pattern where the vast majority of trials land on the left. The only agents that have statistically significant results here, liraglutide in the LEADER trial and oral semaglutide in PIONEER 6. But in the meta-analysis, the overall hazard ratio is 0.87, indicating a 13% reduction in the risk of cardiovascular death with GLP-1 receptor agonists. And then with regards to stroke outcomes, again, we see that most of the dots land to the left of the line. The meta-analysis suggests a hazard ratio of 0.83 or a 17% reduction in the risk of stroke. The only study with an individually statistically significant result is dulaglutide in the REWIND trial. But in the meta-analysis, a lot of interest in the potential of GLP-1 receptor agonists to reduce the risk of both ischemic and hemorrhagic stroke. And then with regards to kidney outcomes, on the top of the slide, the composite kidney outcome, including macroalbuminuria, and we see again all the dots landing to the left, the meta-analysis suggesting a 21% reduction in risk. And then on the bottom of the slide, the restricted renal endpoint looking only at kidney function, doubling of serum creatinine, 40% decline in eGFR, kidney replacement therapy or death due to kidney disease. And you can see a bit more heterogeneity, but at the bottom line, the hazard ratio overall 0.86, suggesting a benefit, but with the variance in the hazard ratio going up to 1.02, so not a statistically significant result in this meta-analysis. There are a number of new areas where GLP-1 receptor agonists are being evaluated, including in the setting of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. And we call this one out largely because it is mentioned in the ADA-EASD management of hyperglycemia statement that we referred to earlier. And, basically the bottom line is that these GLP-1 receptor agonists, perhaps through the GLP-1 receptor or perhaps largely mediated by weight loss, have been evaluated in people with fatty liver disease and seem to have very favorable effects on liver fat content, insulin resistance, and body mass. Though none of the GLP-1 receptor agonists have gotten an FDA indication for the treatment of fatty liver disease, there are very promising results that will be evaluated further in ongoing clinical trials. So the other area where these meta-analyses are exceptionally useful is looking at safety findings, because there have been concerns that these very potent glucose-lowering agents might be associated with severe hypoglycemia. In one of the studies, there was an increased risk of retinopathy adverse events, and there has been a concern since the early days with exenatide about the possibility of pancreatitis. being increased with GLP-1 receptor agonists as well as pancreatic cancer, which is thought of as a sort of end-stage manifestation of chronic pancreatic inflammation in patients at risk. But you can see from these clinical trials involving tens of thousands of patients and average follow-up on the order of 3 years that there's no increased risk of severe hypoglycemia and statistically no increased risk of retinopathy, pancreatitis, or pancreatic cancer across these multiple cardiovascular outcome trials. So let's get back to Joshua. He's a 45-year-old gentleman. Remember, he gained weight over the last 14 months when we saw him last. His BMI is now 32, his A1C 7.3%, his LDL is too high. What do we need to do for him? He needs at least a 0.3% and probably closer to 1% reduction in A1C to get down to less than 6.5%, which might be a reasonable goal for a young guy with new onset diabetes. He needs at least a 10 millimeter of mercury reduction in his blood pressure. He needs at least a 30% lowering of his LDL cholesterol to get at least less than 100. And he needs to lose at least 5% body weight to have a meaningful effect on glycemic management, but arguably with a 10 or 15% lowering, he might even have remission of his diabetes. And then because he's an electrician and works a lot of hours, it might be ideal for him not to have, his life interrupted by hypoglycemic events or extra trips to the bathroom, et cetera, et cetera. But he doesn't have any kidney disease. He doesn't have any atherosclerotic cardiovascular disease, stroke, or neuropathy. So there isn't a particular indication for using any agent specifically. So let's talk about some more of the details regarding patient-centered diabetes care with GLP-1 receptor agonists. So I want to introduce you to Linda. She's 66 years old. Her BMI is 36. Her A1C is 7.7. Her LDL is less than 100, but perhaps not as low as we'd like ideally. She does have some chronic kidney disease with an eGFR of 48, so stage 3A, and a urine albumin to creatinine ratio that's normal, at least on an ACE inhibitor as a background therapy. She has a past history of obesity, type 2 diabetes for 8 years, hypertension, hyperlipidemia, atrial fibrillation, and chronic kidney disease. She's on 4 drugs for her diabetes: metformin, glyburide, a DPP-4 inhibitor, and SGLT2 inhibitor, 2 agents for blood pressure, lisinopril, hydrochlorothiazide in a combination, rosuvastatin for her lipids, and apixaban to manage her embolic risk with the atrial fibrillation. She said something that I think would give all of us pause, that she has her doubts about her type 2 diabetes medications. Certainly makes me wonder about adherence, how good she is at taking her medications as prescribed every day. She is fearful of needles, but she is concerned about her kidney disease. She doesn't like the sound of chronic kidney disease in her case. So, I think one of the most important points in the relationship between a doctor and a patient is to really establish engagement, help the patient understand that you're really interested in helping them be the best them that they can be. So early in the course of therapy, I think it's important to establish goals and targets together with the patient. This is not a demand from the provider, but an engagement from the patient based on your being able to provide them insight into the role of these various factors on their future health. So these should be personal goals, that I'd like to be able to dance at my daughter's wedding in 10 years. Lifestyle goals, diet, physical activity, and glucose monitoring, glycemic goals, A1C, glucose monitoring, weight, blood pressure, LDL, and others. And in general, I think it's ideal to write these down and provide a copy to the patient and review them at least annually. The great thing about that is that that way the patient can help you stay on top of their goals, and you can help the patient do the same. In general, the path to successful management of type 2 diabetes is recommended around shared decision-making. The patient is the person who's going to have to do the diabetes care 24 hours a day, 7 days a week for the rest of their life. We are like coaches. And then we have some extraordinary coaches available to us in the form of diabetes educators. So the provision of diabetes self-management education and support beyond what the provider can do in the regular office setting, with prescription management, et cetera, et cetera. It is really important to make sure that social determinants of health are adequately assessed in people that have housing insecurity or difficulty getting back and forth, or have difficulty paying for their prescriptions, or are being abused at home. It's going to be really hard to manage diabetes in that setting. So we need to adequately assess those factors and then engage support to address them. And then we have to continuously, at every visit, reassess where people are with regards to their lifestyle and other goals. We need to help them with regards to adherence and persistence in a engaging and non-judgmental way. And then above all, avoid clinical inertia, meaning if people aren't achieving goals, it's not a call 911 issue. On the other hand, there are national and global data that suggests that patients and providers delay advancing therapy for blood pressure, cholesterol, diabetes for 12 to 18 months or longer in patients that are not meeting targets. And that's probably too slow a progression of therapy. And we should personalize our diabetes care. And what we mean by that is to provide a personal touch to make sure that you really understand the patient and where they live. At least having a mention at every visit on improving lifestyle being an essential element of all glycemic management, recognizing that in the absence of lifestyle attention, there is no adequate medication management program. The essence of the personalized care is your sort of personal touch and engagement. And there are clear data that empathetic, patient-centered, shared decision-making and support is associated with better outcomes. Teach your patients and do not preach. Motivate your patients and try not to castigate. That everything else of medicine beyond the prescriptions and the devices is essential. How you look them in the eye, the tone of the voice that you use, and how you explain things. And with regards to the goals of therapy, there is no one solitary goal. In general, the A1C goal is viewed as less than 7% without significant hypoglycemia. Lower A1C goals are likely beneficial and certainly may be acceptable if it can be achieved safely without significant hypoglycemia or other adverse events. Less stringent A1C goals, like less than 8%, are appropriate in people with limited life expectancies or where the harms of treatment are greater than the benefits. And particularly in the advanced elderly or in people with hypoglycemia, there is specific recommendation to consider de-intensification of therapy in those settings. Older adults who are healthy with few coexisting chronic illnesses and intact cognitive function should have lower targets than 8% if you believe that they have a life expectancy of, more than 5, certainly if it's more than 10 years. But a target in the 7 to 7.5 range might be appropriate, whereas those that have multiple coexisting illnesses, cognitive impairment, or functional dependence, the higher targets would be reasonable. And in even the most advanced elderly patients, we need to be careful not to completely throw in the towel with regards to glycemic control. Above an A1C of 8%, and particularly above 9%, patients are going to have more problems with symptoms related to polyuria, polydipsia, risk of acute hyperglycemic decompensation, dehydration, urinary tract infections, slips and falls while people are trying to go to the bathroom in the middle of the night, that sort of thing. So I think in general, an A1C target of less than 8% for all is probably reasonable, but certainly extra attention if the A1C is greater than 9%. Now, I think one of the most important papers of the last year was this paper by Ildiko Lingvay, who proposed that we could think about alternative targets for managing diabetes, and suggested the majority of patients with diabetes could be rethought of as having adiposity-related diabetes, where the major morbidity was obesity. Our focus should be weight-centric. The goal should be greater than 15% weight loss, and this is based on data to suggest that in the sort of 10 to 15 plus percent range, that we have the possibility of having diabetes remission in a substantial proportion of patients. She estimates that around 50% or so of the population have this form of diabetes. And in that setting, we should be considering intensive lifestyle therapy, weight loss drugs, surgery, GLP-1 receptor agonists, SGLT2 inhibitors, and metformin. And the secondary targets beyond weight loss would be glucose, blood pressure, and lipids. In the middle column, she proposes a second group of patients, people with diabetes with cardiovascular disease. And the focus there is on the cardiovascular system. The aim is proven cardioprotection. Again, this is about 25% or so of the population. And here, the diabetes agents to consider are GLP-1 receptor agonists, SGLT2 inhibitors, and perhaps thiazolidinediones. And the secondary targets beyond cardiovascular risk protection would be weight, glucose, blood pressure, lipids, and coagulation. And lastly, the minority, about 15 or so percent, would be patients with isolated hyperglycemia, where the focus is really on glucose. The goal should be an A1C of less than 7%, and the primary driver really is beta cell dysfunction. This is functionally type 1 diabetes and very insulin deficient type 2 diabetes. And in that setting, the therapy should be insulin, GLP-1 receptor agonists, even consideration of sulfonylureas. This really changed the way that we thought of things and was a paper that was really a primary driver of our shift in the ADA-ESD guidance that we've talked about a couple of times. The second new area of focus is understanding where people are with regards to their kidneys. Kidney disease is one of the most stubborn complications in diabetes. We have not been able to really fully eliminate it in patients with great access to care. And the way we characterize chronic kidney disease is based on GFR and stage from G1 to G5, and then from albuminuria, also in stages from A1 to A3. And you can see here, for instance, in the current case study, she had a albuminuria on the order of 25, and her eGFR, if I remember, was 48. And check mark has been applied here, puts her in the yellow range, which is moderate chronic kidney disease. The important thing from this kind of analysis is as you go to higher levels of albuminuria and lower levels of EGFR, there's much higher risk of progression to end-stage renal disease over intermediate time frames. And in particular, in the high, in orange, very high, and extrapolated high risk chronic kidney disease patients, the recommendation is to seek assistance and consultation with a nephrologist. So with regards to how do we use GLP-1 receptor agonists based on renal status, the important thing to know is that the Exendin-4-based therapies, exenatide, lixisenatide, and even exenatide once weekly, they should not be used in patients with advanced chronic kidney disease because they are cleared renally. And they can be used in patients with less advanced chronic kidney disease, but they require monitoring. For the other agents, the human-based agents, it's really about monitoring the creatinine in particular as you use GLP-1 receptor agonists. The concern is that in patients who have nausea, vomiting, particularly if it happens to be in combination with diarrhea, which I personally have never seen, but it does happen, that those kinds of patients can get acute on chronic renal insufficiency. But in general, I do think these agents are underused in the setting of chronic kidney disease, even dialysis, because they do provide meaningful benefits for cardiovascular endpoints, and that is the leading cause of death in patients with chronic kidney disease. So when should you use a GLP-1 receptor agonist and when should you use an SGLT2 inhibitor? So this is a sort of meta-analysis provided in the British Medical Journal earlier this year, looking at SGLT2 inhibitors on the top row, a GLP-1 receptor agonist in the middle row, and then tirzepatide, a GIP and GLP-1 receptor agonist. Everything is in gray or most things are in gray for the tirzepatide because we just don't have as many studies. It hasn't been around as long. The SGLT2 inhibitors provide for great benefits with regards to cardiovascular endpoints, heart failure and chronic kidney disease in particular, and also improvements in health-related quality of life. The one area that doesn't seem to be a strength for the SGLT2 inhibitors is non-fatal stroke. The GLP-1 receptor agonists, on the other hand, great cardiovascular benefits, great improvements in health-related quality of life, not as much benefit for heart failure and kidney disease, but certainly effects in the right direction. With regards to severe hypoglycemia, there's really no indication for any of these causes in that regard. And then the actual known drug-specific adverse events are listed there on the right. And when you look on the far right, you see the body weight changes in kilograms from these various different agents within the GLP-1 receptor agonists and the SGLT2 inhibitor class. And I would just point out that in general, the GLP-1 receptor agonists I mentioned before are the most effective weight loss therapies currently available. And then with regards to the issues that affect adherence and persistence with GLP-1 receptor agonists, in slightly older studies, so this is a compilation of data from older studies, the reasons for treatment discontinuation were really related to inadequate blood glucose control, gastrointestinal side effects, and preference for oral medications over injection. These newer agents generally provide for outstanding blood glucose control. It's all about helping people understand that with the once-weekly agents, it takes a while for the drug levels to build up. So the glycemic benefits may take several weeks to months to be fully expressed as you increase the dose. The gastrointestinal side effects are generally mild to moderate. And with slow titration of the drugs, virtually everybody can tolerate these agents. And we just need to go slow for best results. With these new injection techniques, they really are essentially painless, certainly no worse than a mosquito bite, and something that patients should be able to work through. It's just a matter of whether you have the time and the inclination to do it. And if you don't, remember that there is the once daily oral semaglutide as an oral GLP-1 receptor agonist, and more innovation coming in that space in the near future. I think the major valid reason for treatment discontinuation is high cost, and we'll talk about some ways to mitigate that in a moment. Higher adherence is associated with people who started at low doses, understood that the injection device was easy to use, had a demonstration of it, and in general, weekly versus daily or twice daily doses. And the biggest driver actually is the weight loss within 6 months and the A1C reduction. So people who are able to get past the titration, et cetera, which is the vast majority of patients, achieve remarkable A1C reductions and weight loss. So commercial insurance coverage for GLP-1 receptor agonists has improved, but varies plan by plan. And, this is not an exhaustive list of GLP-1 receptor agonists, and it's not an exhaustive list of insurance companies, but I just point out that the vast majority of insurance schemes in the United States, and certainly Medicare, covers GLP-1 receptor agonists in virtually everybody with type 2 diabetes. Now, this data is really disturbing to me. So we spent billions, literally billions of dollars on these cardiovascular outcome trials to demonstrate that GLP-1 receptor agonists and SGLT2 inhibitors provide for reductions in heart attack, stroke, cardiovascular death. But less than 25% of eligible individuals with type 2 diabetes and atherosclerotic cardiovascular disease are using either a GLP-1 receptor agonist or an SGLT2 inhibitors. As you can see, the trends are improving, but we have a long way to go. So job number one is, if you have patients with atherosclerotic cardiovascular disease or at very high risk, or you have patients with chronic kidney disease or heart failure, they should be treated with one of these agents. And we discussed, when you might prefer one versus the other. If patients are having problems getting their medications, there are ways of reducing costs. So there are formulary tools that can help you figure out which specific agent is covered by the patient's particular insurance company. There are retail pharmacy pricing guides. There's medication access programs. We have a pharmacist that works in our clinic almost exclusively helping patients figure out how to get access to coupons and special exceptions, even in the setting of Medicare, which I previously didn't think was possible. But in any case, there are ways of working the system to improve the ability for patients to afford these medications. So let's get back to Linda. So as you remember, her BMI was 36, her A1C was 7.7. She does have chronic kidney disease, and there's some concern about persistence and adherence, and maybe, how much she's really bought into her type 2 diabetes management program. With an A1C of 7.7, she needs at least a 0.7% lowering of A1C. She arguably might benefit from a bit more. It would be great to figure out how often she's taking the medication that she's taking and why, there's this doubt going on. But simplifying her regimen might be helpful. She would benefit from weight reduction, as would we all. She has the possibility of even having a remission of her diabetes with 10 to 15% weight reduction. And again, with regards to adherence, she may benefit from having a simplified regimen. She is at high risk for stroke related to her atrial fibrillation. She is high risk for vascular disease based on her risk factors, and particularly the presence of chronic kidney disease. So I do think those are the most important considerations, the cardiovascular risk and the renal risk. So when you start a GLP-1 receptor agonist with high weight loss efficacy, and this would be particularly tirzepatide and semaglutide, but basically all the GLP-1 receptor agonists, the recommendations that I provide for patients is to eat small servings, a half a cup to a cup in size, to try and eat slowly, and to stop eating when they're no longer hungry. To minimize nausea and reflux, they should probably, they don't have to absolutely avoid alcohol, but be careful in that regard, and try to reduce the amount of fat content of their meals and the spicy foods that they consume. The adverse effects of weight loss, independent of the therapy, whether it's nutrition-based, drugs, or surgery, is a loss of muscle mass, fluid and electrolyte deficits, cold intolerance, constipation, and gallbladder events. To mitigate that, it's important that patients get at least 1 gram per kilogram per day of high-quality protein intake. And some people are now suggesting 1.2 grams per kilogram per day. They should drink plenty of water all through the day, both to help with constipation, but also dehydration. People underestimate how much of their fluid intake actually comes from food. They may need to increase their sodium intake. And in particular, I tend to recommend tomato juice in the morning, soups during the day, broth is one recommendation that many people eat. To eat vegetables and other sources of fiber to help with constipation, which is almost 100%. Almost 100% of people with substantial weight loss are likely to note decrease in stool frequency. Not so much discomforting constipation, but worrisome reduction in bowel habits. They should exercise preferably 5 days a week or more, and strength training in some ways is probably more important than cardiovascular training, particularly in the setting of weight loss. And to mitigate the cold intolerance, people just need to take a jacket with them everywhere. It is very common in people who lose weight. The sense of well-being and the enjoyment of food does get better once the rapid weight loss resolves, generally after 3 to 4 months. And people do feel better and invigorated once they have reached a new stable weight. So to summarize, screening and early intervention for type 2 diabetes appears to improve outcomes. So please do screen people based on the guidance provided. Selected GLP-1 receptor agonists and SGLT2 inhibitors have compelling indications for use in those at high risk for cardiovascular disease, heart failure, and chronic kidney disease, and this is independent of A1C or background therapy. GLP-1 receptor agonists are particularly compelling choices if atherosclerotic cardiovascular disease or stroke risk in particular is elevated, and if the A1C goals cannot be reached with oral medications, as they are the most powerful glucose-lowering drugs, or if greater than 10% weight loss is needed. Not all GLP-1 receptor agonists are the same. Dulaglutide, liraglutide, and semaglutide are the only ones with cardiovascular indications. And the path to successful management involves empathetic, personalized, shared decision-making and support, arrange the assistance of community resources for diabetes self-management, education, support, and do address social determinants of health. It's important that you continuously reassess the goals that patients are pursuing and a focus on adherence and persistence. That ends our discussion for today. I hope you found the activity informative. Please check out the practice aids as they may be useful to you every day. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZKJ860. This activity is supported by an educational grant from Novo Nordisk Incorporated.